Thank you, everyone. We're at the top of the hour and we will get started. We are moving on to the public comment section of the meeting. This is, let's see, give me a second. Okay, thank you. I'd like to welcome and thank our public comment speakers today for addressing the committee. All of the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period. And in order to make it through all of the listed speakers, it's extremely important. Each speaker limits his, her, or their remarks to 3 minutes. We'll be displaying a timer on the screen that you can see there so you know how much time you have left. And as a general reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at the meeting today. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker is Ms. Susan Hepworth.
Thank you so much, and thank you for this opportunity to make these comments on behalf of the National Coalition for Infant Health. We're made up of more than 200 professional, clinical, community health, and family support organizations, all with the focus of improving the lives of all infants and their families. So I just first want to thank the committee for prioritizing this review of this immunization. I know the committee has undertaken so much over the last few years throughout the public health emergency, so we appreciate your prioritizing this review among what I know are many other competing priorities. So we're incredibly pleased and want to thank you for voting in favor of the VFC resolution. This is a huge step towards ensuring equitable access and reducing the burden of RSV. I would like to make one additional comment, and that is that the coalition's strong support of equitable and timely access to this prevention in hospitals, birthing centers, and provider settings. I know this was something that wasn't included in a recent letter from the American Academy of Pediatrics as well. With strong, clear guidance and recommendations from the CDC for babies to receive this new immunization prior to being discharged from the hospital, all babies will have the opportunity to be immunized and protected before they even leave the hospital setting. And I think this measure is what's truly going to ensure equitable access for all infants. And it's also going to ensure a major reduction in the burden of RSV. And as has been spoken about in prior meetings, the burden of RSV is multifaceted. It's not just medical, but it is emotional and it is financial for families as well. So with clear guidance, I think we'll be able to ensure that we will not further existing health disparities. So I just want to thank you all for what you do to protect and improve the health and safety of our nation's infants and children. And thank you for the opportunity to give these comments.
Thank you for your comment. Next, we'll move on to Laura Burns.
My name is Laura Burns, and I represent TRAPAG, the Transplant Recipient and Immunocompromised Patient Advocacy Group. Being immunocompromised and vulnerable to disease, we have a deep sense of kinship with the infants so vulnerable to RSV. We urge you to protect these children and to recommend nirsevimab for RSV prevention. It's been approved by the FDA, and with your vote, it will be covered by insurance as required under the ACA. But insurance only covers about 50% of babies. So ACIP members, we entreat you to resolve that nirsevimab be added to the Vaccines for Children program so that all babies can be protected. One second. Nirsevimab would be the first passive immunization product to be included in the CDC immunization schedule. But we think that there is little distinction to be made between active and passive immunization. The key is what prevents disease. Indeed, Congress sees this way too. For under 26 USC 4132, the term vaccine means any substance designed to be administered to a human being for the prevention of one or more diseases. Nirsevimab fits that bill. Looking to the future, TRAPAG anticipates you will be faced with a similar decision greatly affecting our health. Our group represents people of all ages, from blood cancers, autoimmune diseases, organ transplants. Since most of us have low or no response to vaccines, in all fairness, we need alternative preventions. A number of monoclonal antibodies, for example, are in development for the prevention of COVID. Invivyd, AstraZeneca, Supernova 3152, also antivirals. If one or more of them passes muster with the FDA, we hope that ACIP will show the same deliberative care for vulnerable adults that you're showing today for infants, and that you recommend passive immunizations when they work. This in turn would guarantee that insurance will cover it. Likewise, as there is no vaccines for adults program yet, the CDC should include whichever preventions work, active or passive, in both the bridge access and the VFC programs. This will ensure equity and that everyone, child or adult, will have affordable access to life-saving immunizations at least through 2024. Thinking back, I want you to know that Evusheld was a godsend for us and for our families and friends who got to be with us. So was RegenCo for post-exposure prophylaxis before that. Unfortunately, not all of us had access. With commercialization, equitable access is an even larger issue, but one you should tackle. And if you will indulge me for just a few seconds, Dr. Lee, we were truly heartened by your comments today earlier about how groundbreaking this step is and how it opens up new avenues for preventing disease in the immunocompromised. And while it may be initially complicated, it will be well worth working through those issues. Thank you, and thank you all very, very much for all you do. We urge you to vote yes on all of these.
We're going to move on to the last public comment speaker of the session, Claire Hannon.
Good afternoon, and thank you for the opportunity to comment on the potential implementation of the RSV monoclonal antibody, nirsevimab. We are excited at this groundbreaking opportunity to protect infants from RSV. I'm Claire Hannon, Executive Director of the Association of Immunization Managers, or AIM. AIM is a membership association whose members direct the immunization programs in the 64 federally funded state, territorial, and local health agencies. In partnerships with CDC, these jurisdictions administer the Vaccines for Children, or VFC program, and work to assure protection of the population through vaccination. Last week, we polled jurisdictions about their ability to incorporate nirsevimab into their programs, including the Vaccines for Children program. And you've discussed this mightily today already. But among respondents, 52% report that their immunization information systems can document nirsevimab, 22% cannot, and 26% report that is unknown. Reported challenges include lack of funding for the IIS vendor and lack of information on coding. 68% report that their IIS can be used for ordering nirsevimab in the VFC program, 14% that their IIS cannot be used, and 18% report unknown. Additional time and funding were the cited barriers to incorporate into IIS ordering applications. Additional challenges cited in the poll include the lack of participation of birthing hospitals in the VFC program, concern about data exchange between electronic health records and IIS, and lack of adequate time and guidance to prepare. The poll demonstrates that time and funding are needed to incorporate this new product into VFC and other existing programs. However, the jurisdictions have not received guidance or assumptions to prepare for a potential recommendation, such as the information needed to incorporate nirsevimab into VFC ordering applications and packaging and storaging information. Jurisdictions have not been able to hold discussions with CDC or IIS vendors to address challenges with coding and tracking. And what's most concerning to the incorporation of this potentially life-saving product into existing childhood programs is that jurisdictions have suffered an average loss of 20% in funding for their IIS due to rescission of COVID funds. ACIP is holding a special meeting in August in order to vote on this life-saving product in time for the upcoming flu and RSV season. However, jurisdictions responsible for implementation have not been involved in the planning discussions. The lack of federal communication to and coordination with jurisdiction immunization programs continues to impact the ability of immunization program managers to roll out new and important products with maximum impact. They cannot be expected to deploy critical products such as nirsevimab without the information and time needed to execute these programs. We urge our federal partners to find ways to work with jurisdictions and provide planning assumptions earlier in the process and to share critical information as it becomes available. Thank you so much for the opportunity to comment today.
Thank you for your comment. With that, we want to thank our public comment speakers, and I also want to thank those who take the time to submit written public comments via the CDC docket as well. We will now move to the next section of the meeting, which is our voting session. I'm actually going to ask if Dr. Jones or someone in the room can please put up the first season vote. I also just want to acknowledge that we moved and seconded both votes together, but we are going to take these votes separately. So the first vote for the first season, please. So vote number 1, infants aged less than 8 months born during or entering their first RSV season are recommended to receive 1 dose of nirsevimab. I'm just going to ask our ACIP members if there's any additional discussion or conversation people would like to have before we open it up for voting. But I appreciate my colleagues already putting on their cameras for the vote in preparation. I don't see any hands raised. Okay. With that, then I'm going to suggest that we move to the vote since I don't see any additional comments or hands raised from the committee members. We will start with Ms. Spata.
Sorry, I couldn't find my unmute button. Lynn Bata, no conflicts, yes.
Thank you. Let's see, Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Paling.
Kathy Paling, no conflict, yes.
Thank you. Dr. Daly.
Matt Daly, no conflict, yes.
Thank you. Dr. Lair.
Jamie Lair, no conflicts, yes.
Thank you. Dr. Talbot.
Dr. Talbot, no conflicts, yes.
Thank you. Ms. McNally.
McNally, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Dr. Cotton. We'll move on. Well, this is Grace Lee, no conflicts, yes. I believe Dr. Cotton had to step away for a moment to see a patient. So Dr. Wharton. Dr. Wharton, I'm counting 10 yes votes.
That's yes, Dr. Lee, we have 10 yes votes and it's unanimous.
Okay, thank you. So 10 yes, 0 no. And with that, we will move on to vote number 2. So children aged 8 to 19 months who are at increased risk of severe RSV disease and entering their second RSV season are recommended to receive 1 dose of nirsevimab at the dose indicated there. Would the members like to make any additional comments? Dr. Lair.
I thank Dr. Long and Dr. Jones and Dr. Sanchez for their feedback on this vote, and I'm more comfortable voting in favor at this time. Thank you.
Thank you. Any other discussion or feedback? Okay. I will, at the end of this second vote, we will open it up if folks would like to add any comments or explain why they voted. But we will move on to the second vote. So I will call on Dr. Lair first.
Jamie Lair, no conflicts, yes.
Thank you. Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Thank you. Ms. Bata.
Lynn Bata, no conflicts, yes.
Thank you. Dr. Paling.
Kathy Paling, no conflict, yes.
Thank you. Dr. Daly.
Sorry, Matt Daly, no conflicts, yes.
Thank you. Dr. Talbot.
Dr. Talbot, no conflicts, yes.
Thank you. Ms. McNally.
McNally, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
And Grace Lee, no conflicts, yes. So I believe we have 10 yeses, 0 nos. Dr. Wharton, could you please confirm?
That's correct, Dr. Lee.
Okay, thank you. And vote number 2 passes. Before we move on to the VFC vote, I'm happy to open it up for any comments from our voting members if they would like to speak on behalf of their vote. Dr. Talbot.
I'm very excited about this. I think this is going to be incredible, but I do think it's been pointed out a couple times that we have a lot of logistics to work out. And I'm looking forward to seeing those logistics worked out, especially with our immunization partners and the AMA and everyone else. But I think this is life-changing and I'm very excited. I just hope we can get through the hurdles.
Thank you, Dr. Talbot. Dr. Long?
Yes, I want to start with the remarkable committed work of our work group, many discussions, all of the things that you brought up. And we believe that we thoroughly dealt with what we could deal with data and made our best assumptions of what we didn't know. This is a milestone. You know, this is the very first antibody protection against a remarkably remaining burden of disease in children. So parents should be very much relieved that they won't have to be concerned about the likelihood that their child could be hospitalized with RSV disease. So we do believe that this is a breakthrough. With every breakthrough, however, we feel the responsibility and the burden that this is the first time that we will administer an antibody universally, so that we did have discussions with the FDA, with VAERS, with FAERS, with the effectiveness plan that's in place, with what we can learn from the vaccine, the safety data link, to be sure that this new innovation is in fact safe. There was absolutely no signal that there was anything that would interfere or that there was any adverse event experienced in the small trials that were done. We also don't think that there is a biologic plausibility, as this is
I think we've lost Dr.
not an antibody, that it will not, is not likely to interfere with any immunization or live virus vaccine, but it's something that we wanted everyone to feel the burden of the necessity for looking, because this is new. We are extraordinarily disappointed with the price setting of the manufacturer. And we want to assure you that should a maternal vaccine be licensed, that we will address the use of this product as well as that licensed product should that come to fore. Thanks very much for all of your deliberations. I'm very pleased with the outcome.
Thank you, Dr. Long. Dr. Sanchez.
Yes, thank you. And really, I absolutely agree with Dr. Long. I just think this is absolutely great and exciting news. It is, it's a product that we've been eagerly awaiting. We've had lots and lots of experience with palivizumab, which has to be given monthly, and the cost as well. And it's something that we have been wanting to give to every single baby. And really, take advantage of its efficacy and safety. And really, it's fantastic news. At the same time, I think this is just the first step, because I think the future is RSV vaccination, whether it's to the mother and to the infant. And I think it's only the first step in the long run, but I think it's an extremely, extremely important step in the right direction. RSV, as we all know, is a huge public health problem. And I know that there's problems with implementation. I am sure we will be able to work through this. And I applaud the CDC and ACIP for what we will be voting on next will be for the vaccines for children. So thank you. Thank you,
Dr. Sanchez. Anyone else? I just want to add, I want to echo all of the comments that were just made about what an amazing milestone this is. The one thing I will say is that it'll be really important for us to continue to monitor both ongoing effectiveness and safety, and would ask that it would be helpful to bring back to the committee in future presentations, as we're following up on those specific areas, to think about the impact of implementation on equity. I recognize that implementation is not necessarily the purview of ACIP, but how it gets implemented and its impact on equity may impact how we rethink our recommendations in the future. So as a learning opportunity for the committee, I think some of that information coming back could be very useful and helpful to us. So thank you. And thank you to the CDC team who just, and the FDA team, everyone who's done just a phenomenal job steering this through and getting this product to market. And we look forward to being able to support implementation going forward. With that, I'm going to suggest that we move on to the VFC vote. Do we have a slide for the VFC vote? Thank you. This is a simple vote. Approve the vaccines for children resolution for nirsevimab for RSV. It's been moved and seconded that we consider this vote. Is there any additional comment or questions people have? Okay, we will move on. I am just going in the order of my screen, so I will call on you and just please state your name, conflicts, and your vote. Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Long?
Sarah Long, no conflict, yes.
Thank you. Dr. Talbot?
Yep, Talbot, no conflicts, yes.
Thank you. Dr. Lair?
Amy Laird, no conflicts, yes.
Thank you. Ms. Bata?
Lynn Bata, no conflicts, yes.
Thank you. Dr. Paling?
Kathy Paling, no conflict, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Thank you. And Grace Lee, no conflicts, yes. And we have 11 yeses, I believe, and 0 no's. And with that, I believe, Dr. Wharton, have we passed the VFC resolution?
Yes, thank you. The VFC resolution has passed.
Thank you. Just gonna open it up once more if there's anything else people would like to say. Oh, Dr. Daly.
Yeah, I would just like to thank our CDC colleagues for their work on getting us to the point where we could vote for this for VFC. I don't think it was an easy undertaking, I suspect. And Dr. Santoli, maybe you could let us know who to thank specifically. But, you know, these folks at the CDC are people tremendously devoted to public health who are trying to do everything they can to make this happen. And I remember when it came up in February, it looked a little more daunting, but yet here we are, you know, voting on VFC. And so I just want to thank the people who saw this as so important that we could include this in VFC so that we could provide the maximum public health benefit for this. So Dr. Santoli, thanks to you and anybody else who helped with that process.
Thank you, Dr. Daly. I know many of us very much appreciate our colleagues at CDC for all the work they do to enable access to these vaccines and also supporting implementation and acceptability. Dr. Sanchez.
I again just want to echo what Dr. Daly said. It's fantastic news. This is just great for our children and for our infants, and this is just great. And so I really want to thank CDC and for all their efforts. Thank you.
Thank you. With that, I think we will plan to conclude our meeting. I want to take a moment to thank all of our speakers, our ACIP members, our ex officio members, our liaison members for all your contributions today. Are there any further business items or objections to adjourning today's meeting?
Dr. Lee, I think we'd like to make just a brief comment here from Dr. Romero.
Thank you. Dr. Romero, please go ahead.
So let me add my thanks to the members of the ACIP, the voting group, the work group, for all the deliberations and all the work that you put into this. I would be remiss if I didn't say that today is a historic event. I think that we will look back on this in a short period of time and see what a major impact this vote has had on the health and well-being of children in the United States. I think that this will mark one of the major accomplishments of the ACIP. So congratulations to all of you, Dr. Mann, Dr. Wharton, Dr. Peacock, all of you. Thank you very, very much for all your help.
Thank you, Dr. Romero. And with that, I don't see any hands raised or any objections to adjourning today's meeting. So I will call today's meeting now adjourned. Thank you everyone for your service today. And we look forward to seeing you in October. Thank you. All right, bye.